We're going to just finish up here with this next slide regarding countermeasures, and then we're going to move into talking about immune deficiencies. So the other countermeasure we just talked about antimicrobials. The other countermeasure I just want to quickly talk about this morning is vaccines. We know obviously that vaccines are kind of your biological preps of either a weakened or a dead pathogen that does stimulate production of either antibodies or sort of stimulates the cellular immunity arm of our immune system without actually causing the disease. So that's why vaccinations are so great, is that it actually engages the immune system the way the disease would without having to actually have the disease. So it creates induction of long-lasting protective immune responses, and you can vaccines are either attenuated organisms, which just means sort of weakened, or they're actually killed or dead organisms. But either way, you engage the immune response. Another type of vaccine that we don't use as often, we use them in more sort of rare situations, are toxoids, so toxoids. They're basically purified toxins that have been sort of chemically, detoxified. So they've lost their sort of toxic aspect of it, but yet they still have their immunogenicity. Remember that term we talked about at the beginning of the class today? They sort of contain still their immunogenicity. So a lot of these things are like diphtheria, cholera, tetanus. These are examples of toxoids that we actually give. So it's actually weakened toxin from that pathogen itself that actually engages the immune system to create sort of immunity to it. Now, the other issue that I just want to briefly sort of discuss is this whole issue about lately in the sort of media you hear more and more about reluctance to vaccinate. There always are those complications of vaccinations like site injection, injection site reactions, and actually getting a little bit sick and fever and those types of things. But they really are rare. The complications from vaccinations truly are rare. The issue is, besides the sort of pain, redness, fever at the site, those kinds of things, more commonly the reluctance to vaccinate are based on inaccuracies. So, like what's the biggest thing that you hear of so much now sort of in the pop culture and in the media regarding reluctance to vaccinate? Autism, right. And it has a lot to do with these sort of potential dangers that these things might have. Nothing has ever been truly, in terms of research, proven regarding vaccinations and autism. But the belief there is that, especially in autism, that there's mercury content in the vaccinations that lead to the development and sort of the creation of autism. So that's sort of, one example, and again, more commonly based more on inadequate information than true complications from vaccinations. Another really interesting one that I remember happening, I don't know, maybe 10 years ago, maybe a little bit more than that, maybe early 2000s, was this issue of the oral polio vaccination in Nigeria. There was, again, not based on fact, it was inaccurate information, but there was thought that there was all of these sort of harmful agents in the oral polio vaccination in Nigeria. So there was thought that there was the AIDS virus in it, that it caused infertility, that it has some cancer, sort of carcinogenic agents in it. And so what happened then is that people started refusing the oral polio prep. So by 3, 5, 10 years later down the road, guess what happened? Huge polio outbreak in Nigeria. I think it was like several years, maybe not even that long, like maybe 3 to 5 years later, Nigeria had like over half of the global polio cases in that one country because of lack of information and inadequate information. So anyway, just kind of a quick little sort of public health kind of consideration when talking about, as clinicians, of educating our patients about vaccines, how they work, why they work, what complications you may see, but then what complications are truly not accurate and not proven. So I just wanted to kind of throw that in there as well, because it's certainly a very sort of ever-present conversation lately. Okay, so now let's talk a little bit about immune deficiencies, okay? So we talked a lot about the way the immune system works in normal circumstances last week. We talked about some things that can sort of jeopardize the way our immune system works already this morning. So now let's talk a little bit about true failure of our immune mechanisms of self-defense. And you can really sort of categorize these deficiencies as either primary immunodeficiencies or secondary immunodeficiencies. So primary immunodeficiencies honestly means that the person is born with a deficient immune system, right? So it's either because of a genetic defect, mostly involving sort of a single gene that can sort of create sort of a genetic anomaly that creates immunodeficiency. Oftentimes what this causes, or what happens with these primary immunodeficiencies, is that lymphocyte development, remember we talked about the B cells and the T cells actually being developed before birth in the fetus, so in utero, it disturbs that. It disturbs that process. So you don't have adequate lymphocyte development in the baby, and then once the baby's born, you never do. So you always have this deficiency of their B and T cells, which you can imagine would cause a major sort of primary immunodeficiency for the rest of their life if you don't have those countermeasures to infection. Then the other arm, or the other sort of type of immune deficiency, is secondary or acquired immunodeficiencies. This is not a primary problem in that there's something specifically wrong with the lymphocytes, or the B or the T cells. It's usually, well, it is caused by some other type of illness. There's some other type of disease or illness that's actually suppressing or creating an immune deficiency. And this is way, 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 way more common than a primary immunodeficiency. You really don't see primary immunodeficiencies all that often in the population. However, a primary immunodeficiency, the hallmark, and it is sort of intuitive, it should make sense to you, because of, it occurs because of impaired function of either one or more components of the inflammatory or immune response. The primary hallmark sort of presentation is the tendency to develop these really unusual, weird, sort of rare infections. I had, when I lived in Philly, a good friend of mine was a NP in the ER at the Children's Hospital there, and she would always say that right at the beginning of like every school year, like sort of, August, September, she'd get this rash of parents, these rash of families coming into the ER with these concerns that there's something wrong with my child's immune system. I mean, they're just always sick. They're just going from one infection to the next, to the next, to the next. There's got to be some sort of primary immunodeficiency problem going on here, because they have been sick for like 2 months straight. And she just kind of always laughs, because it's totally normal for preschool or sort of school-aged kids to have like 6 to 12 infections a year. I mean, they literally at school, I mean, if there's parents in the room, you literally know that they just pass one thing on to each other, and then as soon as you get over that thing, it's something else, and then as soon as you get over that thing, it's something else. And same with adults, really. It's not all that uncommon, for us to have 2 to 4 infections a year. That's normal. And usually these things are, not severe. Upper respiratory infections, strep, for kids, middle ear infections, those types of things. So even if you're seeing a lot of them, even if you're seeing one after the other, after the other, after the other, if there's these more sort of common things, we're not too worried about a primary immunodeficiency. But she kind of always laughs that, every year there'd be this epidemic of primary immunodeficiencies in Philadelphia. Everyone's coming because they're all sick and they've been sick for 2 months straight. What I'm talking about with a primary immunodeficiency is that you're seeing these really sort of rare, strange infections. So things like pneumonias and bronchitis and weird blood infections and meningitis and things like that just are not normally seen. Those aren't the types of things that kids pass from kid to kid to kid at school. So that's what I'm talking about with the primary immunodeficiency. I'm not talking about a kid that always has a runny nose, or a kid that always has a sore throat or an ear infection or something like that. I'm talking about these really sort of strange, weird, rare infections. That's when you're starting to get concerned about a child having a primary immunodeficiency, if that makes sense. Okay, so here actually is just sort of a list for you of some reasons, or the 5 different groups, if you will, of a primary immunodeficiency. So as you can see here on the screen, they could have a deficiency in really any one of those different types of cells that we talked about last week. So they could have a B cell deficiency, T cell, they could have a combined deficiency, or they could actually have defects or deficiencies in some of those plasma protein systems that we talked about last week. So a complement deficiency or a phagocyte deficiency. We're not going to spend a lot of time on talking about primary immunodeficiency today, but I wanted to just kind of give you a good list of those 5 groups. So obviously you can imagine if a child is born without B cells or a child is born without T cells, you can imagine then the sort of risk to their health and their risk to their immune system that creates. Okay. What I do want to spend a little bit more time talking about today is this issue of secondary immunodeficiency. Now, as I mentioned already, it's due to some other type of disorder. It's not just pure and true immunodeficiency. It's because of something else. So that's why it's also referred to as sort of acquired. Far more common than primary. And the complications of a secondary immunodeficiency, it's really a complication of another disease, as I mentioned. And it can be relatively minor, but not always minor. So a really classic example of a secondary immunodeficiency is AIDS, is the acquired immunodeficiency syndrome. So that's what I want to sort of spend some time on talking about today, is talking a little bit about AIDS as a secondary immunodeficiency and kind of making some sense of that under this lens of secondary immunodeficiency. So really quickly, before we go into that, before we spend several slides talking about HIV and AIDS, I want to just, and here's a couple of good lists here of some disorders that can certainly cause immunodeficiency. So things like pregnancy can certainly do it, infancy, aging, again, because of those defects in the immune system that we talked about last week. We know that stress can change hormone levels that actually decreases the immune system. And then, again, you see some other issues here on the screen that can certainly cause secondary reasons for why someone might be immunodeficient. I'm not going to spend time talking about each one of those. Okay, so before we move on to AIDS, talking about it as sort of the hallmark secondary immunodeficiency, we have to do a little bit of discussion here regarding, okay, so great, but how do we know? How do we clinically know that someone has an infection or has some type of immunodeficiency? Again, I always try to like to bring it back to the bedside, make it relevant for you. So if you're in clinical and you're looking at your patient's lab values, which labs tell you about immunity? Anyone know? I mean, I have them here on the screen, but anyone have sort of, true real life experience with any of these lab values yet? Yeah, okay. Sure. Well, yeah, sure. Okay. Great. Looking for deficiencies. And did they find any? Yes. Oh, interesting. IgG. Very interesting. Very interesting. So we talked about all those immunoglobulins last week. So that's really interesting. I'm sure that was sort of coming to life for you a little bit. Yeah, interesting. I was actually going to guess IgA. And the reason I was going to guess IgA is because it's the immunoglobulin that's present, or the antibody that's sort of present in our secretion. So you were saying like sinus infections and stuff. So I would have been wrong. Thank you for sharing. So she mentioned one of the blood tests that she just mentioned was the CBC, complete blood count. This is the lab that we draw to know all the sort of cells in the blood, so knowing the levels of the cells in the blood. So red blood cells, white blood cells, platelets. And what's really beautiful about the CBC is not only can we draw a CBC to find the levels of those blood cells, we can also do a CBC with diff. So you'll oftentimes hear it referred to as a CBC with diff or differential. And with a differential, it actually kind of differentiates out all of the different types of white blood cells. So you don't just get a sort of general white blood cell count, you also get lymphocyte count, monocyte count, granulocyte count. So it actually differentiates all the white blood cells out for you and is tremendous help in learning more about what's going on with this patient. Is it an acute infection? How high are these levels, etc. So these subpopulations of lymphocytes that you can find in a CBC is super helpful when talking about evaluating someone's immunity. Another thing you can do as was just mentioned here, is a quantitative determination of all the different types of immune globulins that we talked about last week. So IgG, IgM, IgA, looking at all those different types of immune globulins that we talked about, it can also sort of subpopulate out for you the levels of each one of those immune globulins. That can certainly highlight and certainly bring a little bit more clear as to what might be going on with someone immune-wise. That's the perfect example. Thank you so much for sharing. Sorry, but thank you. So that's a perfect example of that. And you can also do specific tests for some of those plasma proteins as well, like we talked about the complement system and things like that. So, I mean, how helpful, right? If you think someone's got some type of immunodeficiency or you think they've got some sort of infection, you don't have to guess, right? You actually draw their blood and get actual counts for some of these things. Super helpful. Good. Okay, so I just wanted to sort of bring that to light and make it a little bit more clinically relevant for you. It's one thing to understand what's going on in the body, but how can we actually find out clinically? So that's good. That's important. Okay, so now let's talk a little bit about HIV and AIDS. I think, all of us to this point in our studies, but also sort of in the media and the pop culture, know and have heard a lot about HIV and AIDS. But hopefully I can give you a little bit of a different light on it today, especially when we're talking more about this conversation of immunity. So we know, obviously, that it's a syndrome caused by a viral disease. We know that. And pathophysiologically speaking, what actually happens is that the virus destroys the body's T helper cells. So what do T helper cells do? Does anyone know? Why are they called T helper cells? There's a bunch of different types of T cells, but why are these called T helper cells? Yeah. Yes. They are what communicate very much between that sort of humoral and that cellular two arms of the acquired immune system. They help the B cells. They tell the B cells when to create those antibodies. Good. So they sort of link together those two arms of that immunity. Perfect. So they're necessary for development of plasma cells and cytotoxic T cells as well. So the fact then that it destroys these really important helper T cells, it then creates a generalized immune deficiency, so across the board, a generalized immune deficiency, and it then obviously should help sort of make sense then that it suppresses the development of immune responses against any other thing that comes into its contact with, so other pathogens and also opportunistic infections. Because not only does the immune system help kill any pathogens that come into our system, it also helps keep those that normal flora environment in check as well. Our immune system plays a big part of that. So if you're immune suppressed, those opportunistic infections like C. diff, like Candida albicans, like some other things we're going to talk about, can sort of proliferate way more easily with a depressed immune system. Here's a couple of sort of just incidents things here for you. Worldwide, incidence means new cases, okay? So this is kind of an old stat, but in 2008, worldwide AIDS, or shall I say HIV, was 33.4 million. And the United States, look at the very stark contrast. In the United States, only about 56,000. So this is really interesting because despite huge efforts in sort of first world developed countries like the United States, it's still a huge efforts. We know that in our country, AIDS has really changed. It's still a major health concern around the world. And the majority of the cases are in places that are less developed. So like sub-Saharan Africa, places like that. What's really interesting to me, though, is that in the U.S., where we have had so much research and so much effort and so much work done on finding ways to treat adequately, finding ways to treat. In the U.S., the numbers have become somewhat stable. And I really honestly did not truly realize this until I kind of started working as a new grad in the emergency room, that really in places where people have good access to care, AIDS and HIV specifically is really more of like a chronic disease. I really did not understand that. Because of work with antiretroviral drugs and all of the sort of combination drugs and treatments and protocols that they have now, people are living with AIDS, or shall I say HIV, much longer without truly actually getting sick. And we'll talk about that in just a minute when I talk more specifically about CD4 counts and things like that. But again, look at those numbers. so different in a developing country as opposed to a country without access to care that HIV and AIDS in places like the US can actually be more of a chronic illness like high blood pressure or diabetes because of the adequate sort of antiretroviral treatment that we have. And we'll talk more about that in just a second. But before I leave this slide, what I really want to drive home to you is the reason that it's so dangerous, the reason that HIV and AIDS is so dangerous is because it does truly, again, if not being treated and not sort of doing, taking care of sort of antiretroviral protocols, it truly does wipe out both the humoral and the cellular arms of the acquired immune system because it wipes out the T helper cells. And the T helper cells are what sort of integrate both of those arms of the acquired immune system. So it really does indirectly and directly wipe out both B cells and T cells, or shall I say the functions of B cells and T cells. Okay. So, as I mentioned already, effective antiviral therapies have made AIDS a chronic disease. We know epidemiologically speaking that it's a bloodborne pathogen. We know that actually, despite sort of its early origins, that heterosexual activity is the most common route worldwide and still is, despite some of the myths or some of the early sort of origins of what people thought about HIV and AIDS activity. Let's talk a little bit here now regarding the pathogenesis of AIDS and hopefully make a little bit more sense to you. So, pathogenically speaking, the AIDS virus or the HIV virus is what we call a retrovirus. So, what this essentially means, or just sort of the pathogenesis in general of AIDS, is that if a cell is activated, so this is what I want you to truly understand that you may not completely have sort of know about AIDS to this point. If the cell is activated, translation of viral information may be initiated, okay? Resulting in the formation of new virions. Now, virions or virions, sometimes you'll hear it referred to, is the actual part of the virus that actually moves from cell to cell, that actually sort of is the infective part, right? That can actually move outside of the cell and go from other cells to create more of an infection, okay? So I'll say it again. If the cell is activated, translation of the viral information can be initiated, okay, so of the virus, resulting in formation of new virions, so new parts of that virus that jumps from cells to cell, causing lysis and death of the cells, and unfortunately also shedding some of that infective HIV particles out into the system, okay, which creates more of that sort of toxigenicity aspect that we talked about. Now, the issue is that when it first happens, just like we talked about with viruses earlier in the lecture, when it first happens, oftentimes the viruses will just sit in the cell and remain dormant. And the viral genetic material can remain latent sort of in those cells for years. So that's exactly what we're talking about when we're talking about, because AIDS is a retrovirus. So that's exactly what we're talking about with these medications that are anti-retroviral therapies, is that initially those cells, those viruses remain dormant in those cells and don't jump outside of the cell from cell to cell. Therefore, the disease does not progress, right? The viral load, the virus, does not spread from cell to cell to cell to cell. It remains dormant in that cell of the body. So if we've got these really good, accurate, strong antiretroviral therapy protocols, it keeps that virus in the cell for long, long, long periods of time. And whenever I say long, long, long periods of time, I mean, honestly, nowadays, 10, 20, 30 years. That is exactly why I say that AIDS, if treated properly in a first world country like the United States, can honestly be a chronic disease. Because if that virion doesn't jump out of the cell and go from another cell to another cell to another cell, and you just have this viral information sitting in your cell without it ever spreading and with it remaining dormant, it's not causing any problem at all, right? It's not attacking the T helper cells. It's not attacking the immune system. You do not have an immune deficiency. It's just simply sitting in your cell. right? And that's exactly why it can be a chronic disease. And that's truly what I want you to understand about this whole issue of what it is, and it's a retrovirus, and that it remains dormant in the cells for a long period of time. But to be clear, even though a virus may be in the cell, yet not really causing damage because it's not jumping around from others to other cells to other cells, as soon as that initial infection has occurred, an antibody is made, right? So an antibody is present. So you could still draw someone's blood, do an antibody test, and they would still be HIV positive. They still are positive for that antibody, but yet an antiretroviral medication therapy will keep it just right there in that cell for decades. So they're HIV positive because the antibody has been made, but they don't actually have viral spread. They don't actually have T helper cell destruction. Does that make sense? Is that a new way of thinking or hearing about AIDS that maybe you haven't heard of or sort of thought of up until this point? Yes? No? Okay, good. So let's talk a little bit more about that. So again, I'm not a biologist. I'm not going to have you understand the exact structure of that particular virus. But what I want you to understand about the virus, about the structure of the virus, is that the virus itself, the protein, binds to the CD4 molecule that's found primarily on the surface of those helper T cells. Okay? Now, the CD4 is, as I said, a molecule found primarily on the surface of helper T cells. Okay? So, normally, someone who does not have destruction of their T helper cells has a CD4 count of about 800 to 1,000. That's normal. And it's not until those T cells actually start to get destroyed by the virus that you'll see a drop in their CD4 count. And in fact, the major immunologic finding in someone who has now converted from just being HIV positive to AIDS is a striking drop in that CD4 count. Because now if the CD4 count has dropped, you now know that the T cells are they're starting to be destroyed. So, with someone who's HIV positive, they are positive for the antibody. With the high CD4 count, they're just HIV positive. They do not have AIDS yet. They have not converted over to AIDS. Now, they're still contagious. They could still transmit the virus to someone else, even if they have a high CD4 count. But they are not actually immunocompromised. They are not actually immunodeficient. They are not immunodeficient until their CD4 count drops below 200. The diagnosis of AIDS is actually made with a CD4 count of less than 200. That's when you actually start to see someone become immunodeficient. I had a lady that I took care of one time in the ER in New York who was this very wealthy, sort of affluent mom of like 3 teenage daughters. She lived on the Upper East Side of Manhattan, and she was coming into the ER for something completely unrelated to sort of HIV/AIDS. I think she was coming in for like a GYN issue or something. And again, to sort of drive home this point of how it's a chronic disease, she is coming in because of some other issue, and I'm going over her past medical history, and it's like hypertension, this, that. Oh, and by the way, I'm HIV positive. I mean, she literally said it to me like, oh, I have hypertension. I mean, it was like she'd been living with this for decades. And I think, again, just to kind of sort of reiterate, she looked completely healthy. She was completely normal, just sort of living with this positive antibody. And I think, if I remember correctly, the way that she became infected was like her husband cheated on her or something. And then, yeah, it was something awful, like devastating. But she was super compliant with her antiretroviral therapy. She'd had it for like 25 years. She was living a completely normal life with her 3 teenage daughters on the Upper East Side, and her CD4 count was like 950. So I mean, yes, she had the antibodies. Yes, she had HIV, but her CD4 count was normal, and she'd been living with this forever. She definitely did not have AIDS. So again, just kind of drive home that story. Okay, so now let's talk a little bit about clinical manifestations and sort of how that ties into the time of diagnosis with HIV. Okay, so at the time of diagnosis, 3 different things can happen, okay? One, if you get tested, or if a patient gets tested, they can be serologically negative. They can have no detectable antibody in their blood. Does that mean that they're clear? Does that mean that they're not at risk? No, why? Why would just a negative, come back serologically negative not mean that they're off the hook? Yeah. It does, right. It takes time to develop antibodies. And as you see here sort of mid-slide, the presence of antibodies against HIV can take a while. So interestingly, if it's a true blood-to-blood contact, like a blood transmission, how you got infected, you don't see antibodies for like 4 to 7 weeks after that transmission. But if it's due to something like because of sexual intercourse, it's even longer. It's like 6 to 14 months before the HIV virus has actually been around long enough to produce antibodies to it. So it's really, especially if it's a patient that's sort of a high-risk population or high-risk lifestyle, it's really important to sort of teach our patients that they really do need to get tested every 3 to 6 months. Because if you just do one and it comes back negative, you might miss it. Because you just might not have had enough antibodies built up to actually test positive for it. Yeah?
So if that comes back negative, then what are the clinical indicators? Like, how would you know if there's...
How would you know to, like, go get tested again? Again, is that what you mean?
Well, I mean, if it's negative, then what, I guess, clues you into the time that you, like, what clues you into the diagnosis of HIV?
Well, then you just have to come back and get it. So that's what I'm saying. If it's a patient who is in a high-risk population, like they're an IV drug abuser, or they admitted to sort of frequent unprotected sex, or whatever it may be, you would just educate them that, yes, you're serologically negative now, and that's good. That's good news. But don't think that you're still possibly not positive. You need to come back every 3 to 6 months and get tested. Does that make sense?
Yeah.
Okay. Yeah. So that's one thing that can happen. You can get tested and be negative. The second thing that can happen is that you would be tested and you'd be serologically positive. So you're positive for those antibodies, but you're asymptomatic. And if you're asymptomatic, that means that the CD4 count is still probably high, that your T helper cells have not been destroyed, and you really don't have an immune deficiency to this point. So this would kind of be the category of that woman that I just mentioned in the ER, right? She was HIV positive, but she was completely asymptomatic because her T helper cells were not being destroyed. The disease was basically under control. Or the third thing that can happen is that you're serologically positive and you're symptomatic, which is truly the early stages of AIDS, right? And so if someone's testing positive and they're symptomatic, what do you think their CD4 count looks like? Lower than 800 for sure. Right, exactly. Probably close to 200, like I mentioned. So that's the 3 different sort of things that can happen at time of diagnosis of HIV. Now, testing for HIV consists of, the first thing that you do is just simply test for those antibodies. You simply test for the presence of those circulating antibodies. Then, if that comes back positive, there's more testing that needs to be done. So there's more complex tests that occur to look specifically for antibodies. The gold standard, or sort of the confirmatory test for HIV and AIDS, is something called the Western blot analysis. You might have heard of this. It truly is sort of the sort of hallmark gold standard test, confirmatory test for HIV. And it's usually done after someone has tested positive, just to confirm, to sort of make sure. Okay. And again, I mentioned that there can be this window period, this latent period, and that's why it's really important to make sure that you educate your patients, if they're in a high-risk population, to get tested for that antibody every 3 to 6 months or so. Now, that was really truly talking about the diagnosis of HIV, but the diagnosis of HIV is just truly the presence of the virus, and the presence of the antibody to the virus. Now, the diagnosis of AIDS is made in association with various clinical conditions and lab tests. So really the 2 things that you need to have present to truly say that someone has now moved from being purely HIV positive to having AIDS is a CD4 count of less than 200 and they've got symptoms. So, and by symptoms I mean those atypical sort of opportunistic infections or cancer. Cancer, there's specific types of cancer that are quite associated with AIDS as well. And again, cancer can sort of grow and proliferate because of the lack of our immune system to sort of suppress some of those troubling cells in our body. So one specific type of cancer that's very much associated with AIDS is something called Kaposi sarcoma. But you can also see other infections like herpes, candidiasis, as we talked about, cytomegalovirus. Again, these things are able to sort of rear their ugly heads because there's no immune system to sort of suppress those things anymore. Okay. Any questions about that? Yeah.
I have a weird question.
Yeah.
So since, you can be serologically negative for a while.
Yeah.
When you give blood, have there been cases of it, not being detected and then people contract HIV because of blood transfusion?
Well, not anymore. Luckily, after early 90s, that's really low. The reason for that is that not only will they, test the blood itself, but they also now are super careful about sort of, those questionnaires that you fill out beforehand. So in combination with testing and some of those sort of lifestyle questions that you do at the beginning, that's not the case. But prior to early 90s, 92, 93, yes, people got it just by pure blood transfusions. Let me continue to move on because we've still got a lot more to cover, and then I'll be happy to answer questions or take comments after class before Batty starts. Okay, so anyway, there is a lot more. I mean, we could do an entire class on AIDS, an entire lecture course. But I just wanted to sort of bring this whole issue of a secondary immunodeficiency to life with this concept of HIV and sort of the clinical manifestations of that. Again, a low CD4 count in someone with HIV has profound effect on the immune system because of severely diminishing the response to pathogens and, as I mentioned with this issue of cancer, to malignant tumors as well. And that's why you start to see what you see in terms of symptoms of someone with HIV converting from HIV to AIDS. Okay? All right. And then for the last few minutes here, we're going to talk about another concept of issues with the immune system that's kind of the opposite. So we just got done talking about immunodeficiencies, so the lack of sort of response of our immune system. Now we're going to spend a few minutes here talking about hypersensitivities. So where the immune system responds too much, okay? And you really can understand hypersensitivities that can be most easily understood in relationship to the source of antigen against which the hypersensitivity is responding. So as you see here, hypersensitivity reaction is sort of an altered immunologic response to an antigen that results in disease or damage to the individual. And the three different types of hypersensitivities, so the over-response of the immune system is an allergy, an autoimmunity, or an alloimmunity. So an allergy is just the hypersensitivity response of our immune system to some type of external something in the environment. So as you know, bee stings, nuts, shellfish, whatever. It's an over-response of our immune system to something from outside in the environment. An autoimmunity is the disturbance in the immunological tolerance of self. So the immune system is oversensitive to, like in the case of someone with an autoimmune disease, to their own cells. Okay, so it's not something out in the environment like an allergy. It's an over-response of their immune system to their own cells. And then alloimmunity, the third type of hypersensitivity, is immune reaction to tissues of another individual. So this is the case of oversensitivity of the immune system to an organ transplant or to a blood transfusion or something like that. Those are your three sort of types of hypersensitivity. And again, you can really understand which type of hypersensitivity it is if you think about what the immune system is over-responding to. Either something in the environment with an allergy, something in yourself with an autoimmune problem, and something from another individual in an alloimmune problem. Okay? Let's talk a little bit about these more specifically. So, allergy first. It certainly is, of those three different types of hypersensitivities, the most common. We know that an anaphylactic reaction is the worst version of an allergy or of an allergic reaction. And allergies are very, very heavily immune globulin E mediated. I think I mentioned that when we were talking about the different types of immune globulins. And we know that it's sort of an overreaction to environmental antigens. So, as I mentioned, pollen, mold, fungi, shellfish, etc. And also, as I mentioned, when we talked about that inflammatory response, it's very, very heavily mediated by histamine release. So again, that's why you see what you see in an allergic reaction. You see that increased vascular permeability where the fluid leaks out into the tissues and causes swelling. You see vasodilation, and you also can see histamine also causes bronchial constriction. So that's why you see airway problems and breathing problems and really severe allergic reactions like anaphylaxis. So there, obviously you see the manifestations there. Itching, urticaria are like those whelps that occur in allergic reactions. Again, that's just really truly because of little localized areas of increased vascular permeability. So it's like little localized areas of edema. That's what causes those whelps that you see in an allergic reaction. And then, runny nose, runny eyes, those types of things, all the way to really sort of severe issues like bronchospasm, so constriction of your bronchioles, dysrhythmias. It can actually impact sort of the electrical activity of your heart, etc. And then sort of the classic example that I just sort of listed there for you would be like an allergy to bee sting. What is the sort of gold standard treatment of an allergic reaction? Do you know what the medication is that we would give someone in the ER? Epinephrine, epi. The reason that epi is so helpful in an allergic reaction is because it is an autonomic nervous system sort of mediator that binds and counteracts all of those effects of histamine. So it binds to the specific receptors on smooth muscle and reverses the effect of histamine. So it is truly sort of your big honkin' mama antihistamine. That's how you can think of epinephrine. It decreases that release of mast cells and mast cell degranulation and decreases that release of histamine that causes the bronchial constriction, that causes the vascular permeability, that causes that vasodilation. All right. The next one is autoimmunity. Again, this is the overreaction of your immune system to your own cells. So breakdown of tolerance, which basically means that it's a state of immunological control so that the individual does not make a detrimental immune response against his or her own cells and tissues. That's what normal tolerance is. Someone with autoimmune problems does not have that. It sees its self-antigens as non-self and starts to attack it. So your body starts to make that inflammatory response and that immune response we talked about last week to their own cells. So body recognizes self-antigens as foreign. And normally, under normal circumstances, the self-antigens that are found on the outside of all of our cells are not even noticed. They're not even seen by our immune system. And in someone with an autoimmune disorder, that is not the case. So their immune system sees the self-antigens as non-self and starts to actually attack them. Interestingly, autoimmune diseases have sort of a genetic predisposition to them. Interestingly, women are more at risk of autoimmune disorders. And oftentimes it's a combination of sort of this genetic predisposition in combination with some sort of environmental stimuli. And sort of it's this perfect storm, if you will, of a genetic predisposition and then maybe coming into contact with something in the environment that really creates this autoimmune sort of response. And our immune system really does function best in balance, right? So if you think about like a scale, and here it's, too sensitive, and over here on this side of the scale, it's, just sensitive enough to create a good sort of immune response. In an autoimmune situation, this balance totally tips. And it's just way too sensitive. It just overreacts about every sort of cell that it sees in the body. And it's detrimental. You don't have this good balance. It's way, way too sensitive. Okay. Now, I have some slides in here for you regarding sort of the classic autoimmune example. That is the disorder called lupus, systemic lupus erythematosus. There are, like as I mentioned, some slides here for you regarding this sort of classic example, and I'm going to just kind of let those slides be there for you to sort of read over and to sort of bring some of these autoimmune sort of example to life. And then last but not least, we'll talk about alloimmunity. So again, this is the type of immune response to someone else's antigens. So it's not something in the environment. It's not our own antigen. It is someone else's antigen that has now been, for lack of a better word, injected or inserted into our body. So immune system reacts with antigens on the tissue of someone who's genetically dissimilar. That now those antigens are now in our body. And there's a couple of different types. There's a transplant rejection, which is like the rejection of an organ that, upon sort of organ transplantation. The MHC, or major histocompatibility complex, is antigens that are present on all of our cells and all of our tissues. And it's this very complex matching of all of these antigens that are on people's organs that they look at, or sorry, I say in their tissues, not on their organs, but in their cells and in their tissues that they look at very, very carefully when doing tissue matching for organ transplantation. And it's very complex sort of system they run these cells and these tissues through. If they do not match, or at least match pretty darn closely, you're going to get a transplant rejection. So the body is going to fight this other person's organ in your body. And again, it has to do with these major histocompatibility complexes that they look at. Another example is a transfusion reaction. So this is a blood transfusion reaction because you have, given someone blood that's not their own blood type. We'll talk about that in a second. And you can also have an RH incompatibility, which is sort of if our body is, if like you're A positive or you're A negative blood, it's that positive or negative that can also cause an issue or a problem with an immune response. And we'll talk about that more specifically in just a second. So let's talk a little bit here about transfusion reactions. So we know, right, that our blood groups, the blood types that we have, consist of two major carbohydrate antigens, A and B, right? So we know that A and B can be co-dominant. So someone can have A blood type, someone can have B blood type, someone can have AB blood type, and someone can have O blood type. I'm going to move to the next slide here for a second. Okay. So in someone who has A blood type, it means they have A antigens, and they make antibodies in their serum against B. Okay? If someone has B blood type, they have B antigens, and they make antibodies against anything that's they make anti-A antibodies. If someone has AB, they've got both A and B antigens, and they don't have antibodies to anything in their blood, okay? And then if they have O, they don't have A or B on their red blood cells, and they make antibodies against A and B. So we'll finish up talking about this, and then we'll finish up, I'll do a quick little voiceover about the rest of it. But given this information, who would be a universal donor? Why? Right, because nobody has antibodies against O. Good. Who would be a universal recipient? Why? Right, because they don't have antibodies to anything else, so they're not going to react to anything else. Good. So I'm going to stop there. I'll do a quick little voiceover finishing up this talk about blood type and RH incompatibility. And I'll also do a quick little voiceover about Chapter 8. It's super quick. There's really not that much information, so it won't be much at all. But I'll do a little bit more information for you regarding this content, because next Monday is fall break, and then the Monday after that, when we have class again, we're going to start going into our cancer unit. So I want to make sure we get all of this information cleared up before we move into that. All right, guys, I will do a quick voiceover for you, and that will be that. Thanks so much.